Hello everyone. Principles of tooth preparation. So first of all, let's know what is tooth preparation. Tooth preparation and for fixed partial denture is preparation of the abutment teeth for where the retainer of the entire fixed partial denture is gonna come. So that tooth, which is called the abutment, to prepare the tooth to receive a cap is called a tooth preparation. Now that will have certain guidelines how to prepare the tooth as well as when to prepare, how much to prepare, where not to prepare a tooth. Now to say for example, what are the parts of fixed partial denture? So the parts of fixed partial dentures are, we saw pontic, connector and retainer. So retainer is that part of fixed partial denture which is coming over the abutment teeth. So, and even if that is not an abutment teeth, tooth preparation is also done for a single crown placement as well. So, anywhere where the crown is gonna come and a crown has or tooth beneath, that preparation of that tooth will be called as tooth preparation. So, what is a fixed partial denture? We saw it can be replacement of a single tooth. It can be replacement of a multiple tooth based on the Anti's law. It can be a single crown placement over a single tooth. So this is a full crown, this is a gold crown. We have partial veneer crowns like the laminates or the veneers. We have intracoronal restorations like inlays. We have extracoronal restorations like onlays or a full crown. We have onlays as well where the cusp is lost and we have to restore back the cusp. We have this bridge, that is a cantilever spring bridge. We have a crown coming over to that. We have all ceramic restorations where we are not using any metal base. We are using a zirconia base and on that we are building up with ceramic. And if it is from a single block of zirconia, then that is called monoblock restoration. Monoblock, as the name is saying, single block. Just that the color and translucency in those cases are not good. All metal crowns or cast metal crowns are there, which we are casting the metal, so that will be called as cast metal crowns. So coming up to the principles of tooth preparation. Based on, there are 5 principles, that is preservation of the tooth structure, structural durability, marginal integrity, retention and resistance form, and preservation of periodontium. BEVEL was a great scientist in our prosthodontics who said meticulous replacement is not important as preservation of the teeth is more important. So what remains, preserve that rather than meticulously replacing that. Why is that so? If a teeth is present, there are certain advantages like the bundle bone is preserved, the bone beneath is preserved, the resorption rate is decreased, the periodontium is healthy. So even if there is no crown, we have different options. We have options of restoring it with the endodontic treatment and then going ahead with post-in core. We have different options. So removal of the tooth structure for tooth preparation is an irreversible procedure. You cannot get back the natural teeth. So before doing that, think twice. 0.5 mm of enamel for a cast metal restoration, whereas 1.5 for porcelain restoration. It is a huge amount of enamel that we are going to lose out. So before placing a crown, you need to see what is still there and preserve those sections rather than replacing which is mixed. So we know the tooth anatomy. There is a crown section, we have the enamel, we have dentine, we have cementum, we have the dentine outside. We have a pulp structure which is there, the pulp horns which is high enough in this area, and we have a pulp chamber, the root canals, nerves and blood vessels always associated with all of these structures. The tooth, the natural tooth, is much more stronger than any crowns that you give to withstand occlusal force. And the crown which is also going to come is supposed to think in that aspect. If it is a posterior crown, you need to think in the aspect that the occlusal load is going to come over it. So that has to be modified. So It must not make the tooth weak so that it will break or fracture. The crown that we are going to place should not be that it is weakening our own natural teeth structure, compromising the anatomy of natural teeth structure, making it brittle, which will fracture nearby. So, for example, if this is a condition of the teeth, now it can fracture from here, fracture from this area. When the occlusal load will come over this section of the crown, then it can fracture this section. So rather, before going this, restore it with a glass ionomer cement or a composite, get back the strength of the tooth and then restore it with a crown. So coming to the retention and resistance form. Now what is retention? What is resistance? We have spoken earlier. Retention is when you retain anything. How do you retain? You pull it like this. So that means you're not allowing it to go down. So anything which will not allow to go along the long axis of the force is called retention. Resistance is resisting the force. What are the forces? The tensile force or the compressive force, the shear forces. Shear forces are the more dangerous forces that does not come on the long axis of the tooth. It can come from any section, any direction. So the tooth, when it is subjected to shear stress, is the most dangerous tooth. So for that, you need to know and correct the occlusion anatomy and the occlusal contacts by selective grinding. So coming to retention, it prevents the removal of restoration along the path of insertion, as I told you, or the long axis of tooth preparation. So what are the things that will resist it? It prevents removing of the restoration by forces directed in the apical direction and prevents any movement of the restoration under occlusal forces. The important part of retention is two opposing vertical lamp which is there on the same preparation. Now the question arises, how much taper are we supposed to give? So that will decide the retention. There are factors which will come across. If it is intracoronal restoration like inlay, it is an internal wall like buccal and the lingual walls or the proximal boxes. The factors affecting retention, like I told you, tapers, freedom of displacement, length, substitution of internal features, path of insertion. Coming to the first one, that is taper. What is taper? Taper is this, convergence. Now the walls, that is the buccal and the lingual, mesial and the distal, all of the walls outside the crown of the tooth, that is the enamel. Now that has to be exactly parallel to get the retention. So the ideal requirement is 0 degree taper. But in a clinical situation, achieving 0 degree is next to impossible. So what is advocated? 0 to 3 degree on each side. So 6 degree taper in both the sides. The wall should taper slightly. That is 6 degree on both the sides. From this side 0 to 3, this side 0 to 3. How will you achieve 0 to 3 degree? When you hold your tooth preparation burr exactly parallel to the long axis of the tooth, not bending it, then you will achieve it directly, because indirectly how will you achieve it? The angulation of your burr has got 3 degree taper already present. So if you hold it straight, it will give a taper of 3 degree altogether. If it is internal wall, the wall must be divergent occlusally. Why is the walls divergent occlusally required? For like in case of onlays, because for easy removal of the particular crown or the intracoronal restoration. If it is converging in this particular section, it will not go in. So it has to be divergent so that easy removal and placement of the intracoronal restoration is achieved. Each wall should have a taper of 3 degree, which I told already. So a total of 6 degrees should be achieved in the full preparation. More the taper, less will be the retention. And because the maximum retention is gone when there is 0 degree taper. Parallel walls will give more retention. That is called the tenso-frictional force of the crown. That is, the crown will remain without a cement in the particular place with the help of tenso-frictional force. Tensile frictional force. When you pull the crown will not come out. That will be achieved when you have parallel walls. So more the taper, less is the retention. Loss of retention. So ideal taper should be 5 to 6 degree, 15 degree taper, 2/3 loss of retention. More than that, total loss of retention. So this is a diagram, a graph which is showing degree of taper towards retention. So you can see more the parallel walls, more is the retention, whereas the more the taper, less is the retention. So it is inversely proportional to each other. Greater the surface area of preparation, greater is the retention. For molar, it is more retentive. So, if we compare a long premolar and a short molar, so which will have more retention? A long premolar will not have that retention rather than a bigger molar, because the surface area matters, not the height of the restoration. Surface area preparation can be increased by adding grooves, of course, sandboxes. If there is a single crown and the crown height is less, the first thing that you're supposed to think is orthodontically moving it up. If not possible, go ahead with crown lengthening procedure. Even if that is not possible by the patient's desire and your time, then you should go ahead with different multiple grooves, and those kind of preparations are called bucket preparations. Now coming to freedom of displacement, as the name is saying, how much freedom are supposed to give in displacing of the crown. Now when there is only one path of restoration and one path of insertion, retention will be more. If there are multiple paths of insertion and multiple paths of removal, that is, the freedom in the displacement is more if there is multiple paths of insertion and placement. A full veneer crown with long parallel wall and groove which produces such retention. On the opposite hand, a short over tapered temporary restoration without retention, because the restoration will be removed along different paths. Coming to the length of the restoration, occlusogingival length is of course important, but both for the factors of retention and resistance. The minimum length of the preparation must be 4 mm. If less than that, we cannot give any restoration. Now, for example, we have a restoration which is to be coming over molars, and we do not have 4 mm of space. So again, we will proceed with the crown lengthening procedure. We will expose the clinical crown, and then we will go ahead with tooth preparation. So retention can be increased by adding grooves in the retention preparation. Now this adding of grooves and the length is pertaining to retention or resistance. It is to resistance property more. It can resist the tensile stress more, because once it is longer, if it is even coming here, the force can be retained by that restoration. Substitution of internal features, like if the internal feature we have already compromised with the sides, we have already compromised with the anatomy, how will we make over it? We will make it with the help of pinholes, pin retain restorations, grooves we will make over, multiple grooves for that matter, boxes, the proximal boxes are also helpful in cases of onlays. Coming to the path of insertion. Now how many paths of insertion should be there? The path of insertion is it should be along the long axis of the tooth, very important. If it is along the tensofrictional forces will allow it to be only one path of insertion. Once there is multiple path of insertion, then we are hampering which law? Freedom of displacement. We are creating more freedom of displacement for that particular crown. So once we are giving more path of insertion, that means the taper is more. Retention is already compromised. Of course, resistance is also compromised. You must see the preparation with only one eye with a distance of at least 12 centimeters. No, 12 inches. I'm sorry. You should always see the restoration with one eye with a distance of 12 inches. Now, why is the requirement of seeing a restoration with one eye closed? That is unilocular, not binocular. It is unilocular action. Why is that so? Because when you are having a binocular movement of your eye, it will create a paradox and you will miss out the undercut which is present in the tooth. Basic concept is we are not supposed to have undercut. How will we watch it? With single eye, closing one eye, unilocular vision with 12 inches distance. Coming to the next property, that is structural durability. The name says structural durability. Structural durability is concerned to crown, or is it concerned to the tooth? It is concerned to both. For tooth, where is structural durability coming into question? Durable as means what? the time that it is gonna be kept without distorting. So durability factor of a crown is based on where the load is gonna come. So where the load is gonna come, where there has to be function. So that cusp which will have function action, that is called functional cusp, and that cusp is more prone to fracture. That means when we are preparing the tool, we need to increase the surface area of the functional cusp. How will we increase the surface area of a functional cusp? Now to do that, we have to place something which is known as functional cusp bevel, and that bevel will be 45 degree in the angulation. Hence, we are increasing the surface area. We are giving more strength to our crown, clinical crown. Now coming to the say of a crown which is going to come over the clinical tooth. That is, in the crown also, when we gave this functional cusp bevel, the metal portion over there will be remaining the same. Generally, metal is how much? 0.3 mm to 0.5 mm. And how much is our ceramic thickness? That is 1.3 to 1.5 mm. So once this functional cusp bevel is given, the metal will remain to 0.3, but the ceramic thickness will increase. Hence, when the force will come onto that particular cusp, the ceramic will not get fractured. So structural durability is concerned to both the crown, the tooth, as well as the crown. So structural durability depends on the occlusal reduction, functional cusp bevel, and axial reduction. Occlusal reduction. Now for every kind of restoration that we are going to give, the occlusal reductions are going to be different. For an all ceramic restoration, the occlusal reduction required is 2 mm. For a metal, it requires 0.5 to 1 mm. For a porcelain fused to metal, it requires 1.5 mm. Now why is this requirements varying? For a metal, it is only 0.3 mm. Metal structure is there, so 0.5 mm is enough. For metal fused to porcelain fused to metal, the metal thickness is 0.3, the porcelain thickness is 1.5. So at least 1.5 to 2 mm is required. Whereas for all ceramic, we need more bulk in that particular place. The line angle should be clear, smooth, not sharp, because it can transmit the force and fracture the ceramic over that. So hence, occlusal reduction for all is same. Coming to the functional cusp bevel, we spoke how and what is it. Maxillary posterior teeth, the functional cusp is parietal cusp, whereas the non-functional is the buccal cusp. Mandibular posterior teeth, the functional cusp is the buccal cusp, and non-functional is the lingual cusp. So structural durability for metal crown, we spoke all this. So for non-functional cusp, we can keep 0.5 mm low for every case. For functional cusp, we have to have the occlusal clearance of at least 0.5 mm higher always, with the functional cusp bevel present. Now occlusal clearance for metal ceramic, 1.5 for functional cusp and 1 to 1.2 for non-functional cusp. For all ceramic, it is 2 mm occlusal reduction overall. There is no clearance, no compromisation on that. The most important thing is, while we are preparing the tooth, we need to follow the normal anatomy of the teeth. If we do not follow the anatomy of the teeth and make it all flat, what will happen? Once the teeth is flat, that means the crown which is made, that has to come with anatomy. Otherwise, the occlusion won't happen with the opposing teeth. So once the crown is coming with anatomy, that means there are so much of unsupported metal and all ceramic present over that, So that ceramic is prone to fracture for sure. So that is the reason that you need to maintain the occlusal anatomy of the tooth when you are preparing it to receive a crown over it. So adequate reduction, inadequate reduction, you need to check. And how will you check for adequate and inadequate reduction? You can use a small wax sheet and press it in occlusion and see if there is any perforation. The wax sheet that we get here is 1.5 mm in thickness. So if there is a perforation, that means it is less than 1.5, and if there is no perforation, you are finally fine with it. Now if there is an inadequate occlusal reduction, what all can happen? The restoration becomes weaker, will not provide adequate space for good functional morphology under the anatomic grooves. It will be easily perforated. So functional cusp bevel, we saw the bulk of the metal in that area, heavy occlusal load it should take, lack of thin area or perforation can happen in those cases, over contouring or poor kind of occlusion can develop if we are not giving a functional cusp bevel. Over inclination of buccal surface will destroy excessive tooth structure, reducing the retention of the crown. In crossbite, where does functional cusp fall? If the patient is having a crossbite, so the buccal cusp of upper will be acting as a functional cusp now. It is the opposite way around. In normal patients, the buccal cusp of lower acts as a functional cusp. In a crossbite patient, buccal cusp of upper will act as a functional cusp. Coming to axial reduction is again important feature because it requires space for adequate thickness of the restorating material that is going to come, that is our ceramic or the metal which we are placing, the crown that we are placing. So adequate axial amount of reduction is important. How much axial inclination or reduction is required? So axial reduction for metal should be around 0.5 to 1 mm. For that of the metal ceramic should be around 1.5 mm, and that for that of all ceramic restoration it should be 2 mm. Inadequate axial reduction will have thin walls of restoration and will distort, or it will result in over contouring the axial surface. What happens if there is an over contouring of axial surface? Now the food particles that we are chewing will get a chance to get inside that contour and sit beneath it. Once the food particle starts accumulating behind or beneath the restoration that we have given, then it will start forming plaque, debris, calculus, and then further going and making a periodontal pocket. So the periodontal health is compromised if our axial inclinations are not great, if we have not reproduced the correct amount of intercuspal position, that is the ICP, the contact positions are not maintained properly, again there will be periodontal problems in the patient. Coming to marginal integrity. What is the meaning of marginal integrity? Now margin is the end, anything of end is called margin. Integrity is it is the feature of the crown that has to be placed, or it is a feature of the tooth on which the crown will come. So it is a feature of the tooth on which the crown will come. So it is the place where the crown is going to come and sit, and the margins of the crown will sit. So that will be decided by the finish line configuration that we are going to give. So a restoration margin should closely adapt to the cavo surface finish line of the preparation to survive the oral cavity, because otherwise what will happen? Again, there will be leaching of cement, there will be leaching of the saliva inside, there will be leaching of any organism or food particles, keeping and failure of food spatial dentures ought to happen. What is the margin of finish line of preparations, and what are the different finish lines that we get? Should it be supragingival or should it be subgingival? Supragingival, as the name itself is saying, something which is above the height of gingiva. Where should we give supragingival and where should we give subgingival? Rosenstiel very clearly states that place supragingival margin wherever necessary. Now, for example, in a posterior section where the aesthetic is not so important, you are supposed to keep a supragingival, because when making a subgingival margin, there is very much chance that you can destroy the gingiva down there, and hence you will compromise with the health of the mucosa. So that's the reason, keep it supragingival. Already the mouth opening is less, the bud not reach to the end, so keep it supragingival so that there is no problem and we are not hampering the biological width of the particular tooth. Coming to subgingival margin, so somewhere subgingival is also important. So where are those cases? Those are the anterior cases, where if you keep a supragingival margin, you can very clearly distinguish between the margin of the crown and your tooth, and that will give very ugly appearance of putting an artificial crown and a tooth onto the natural teeth. Any patient who comes up to you for a treatment or getting a crown over a tooth do not want to be noticed by his or her viewers saying that this is your artificial teeth. So for that you need to make a supragingival margin. As aesthetics is concerned, subgingival margin is important. What are the different finish line per se, may it be supragingival or subgingival? Different finish lines can be shoulder, chamfer, knife edge, feather edge, shoulder with bevel, and it can be heavy chamfer, or also known as, it is also known as radial shoulder. Now coming to the different margins, first is chamfer. Where are we supposed to place a chamfer margin? You can see a chamfer margin where it is not of 90 degree. It is just slight curvature which is present. So for the restorations of metal metal crowns, a chamfer margin is enough. So what burr is supposed to be used? Torpedo shaped burr. Now the shape of the burr is itself like this. It is straight and then it has a curvature downwards. So just placing the burr will give you a chamfer restoration margin. Conservative when prepared with the shoulder margin. It is more conservative when you compare it with the shoulder margin. Now heavy chamfer, or also it is known as radial shoulder in Schellenberg. What does that mean? Radial shoulder is that kind of shoulder. First let's see what is shoulder, then we will come to this. Shoulder restoration is the 90 degree restoration. Like our shoulder, it is 90 degree to our neck. The similar way we are supposed to make the margin or the finish line in the crown. Now why do we need to do that? Because in a metal ceramic restoration, remember a metal ceramic restoration, we have a metal which will come till half of this. Then we have a ceramic which will come over that. So we need to support the metal and the ceramic. So we need to have a platform where both can come and sit. If we had a chamfer which is going downwards like this, so then the metal will be placing a rest on that, but the shoulder will be hanging. The ceramic will be hanging. So we need to have something which is 90 degrees. So metal will also come and a ceramic will also come and it will rest on the shoulder. So that how we use that? So we use flat tapered burr diamond points for shoulder preparations. Now coming to this shoulder preparation, here you can see a 90 degree bend between the cavo surface and that of the margin. So this 90 degree bend in an all ceramic restoration is not indicated. So when this particular bend will not remain 90 degree and will have a curvature like this, a U-shaped curvature like this, that restoration, that finish line will be called as radial shoulder or heavy chamfer. So for full ceramic restoration or all ceramic restoration, you are supposed to use a round end tapered diamond and make the margin, see here not 90 degree, it is U-shaped margin so that it will not fracture and the force is not concentrated in that particular place. Wherever there is 90 degree, the force will be concentrated. That is the reason where there is 90 degree of shoulder, what is coming over here? Metal. So the force what is concentrated on the metal. So metal is enough strength to take over the force and not the ceramic. Shoulder with a bevel for inlay and onlay preparations. Why do we need a bevel? To increase the surface area and increase the retention. Knife edge. There are certain cases where you will find that there is enough recession, exposure of the root surface, but the crown which is supposed to be given should be covering the clinical crown of the tooth. So once you are covering the clinical crown of the tooth, that can involve some area after CEJ, that is cemento-enamel junction, that is the root portion. Now if you start making a proper shoulder or a chamfer in a root portion of a vital teeth, the patient will have sensitivity because the nerve endings are very near to that of the cementum. So what are we supposed to do over there? And of course, cementum is weaker in structure than enamel or dentine. So what are we supposed to do? We are supposed to make a knife edge kind of margin over here where our restoration can go and face out. Many a cases, many a practitioners in a metal ceramic restoration also in the lingual side or the palatal side which is not seen or visible use a end with a metal margins. Ceramic is ended little up and then there is only metal collar which is coming. In those cases also you can use a knife edge margins. Also in the cases where the teeth is tipped lingually. So in those cases if you start making a full metal ceramic, for a metal ceramic start making a shoulder margin, you're compromising with the clinical crown and you're compromising the first characteristic of tooth preparation, that is preservation of tooth structure. So there as well we can go for a knife edge margins. So coming to the last property of tooth preparation, that is preservation of periodontium. After all this, we are knowing that we are preserving the tooth, the retention form, the resistance form, where to get the structural durability from, how to make the integrity of the margin much better. Now let's see what is there beneath the tooth, that is periodontium. How much are we supposed to go in the periodontium? So we need to see now how is the periodontium preserved with the help of the finish line that we are giving. So in case we are giving a subgingival finish line, as I said, it should not be going beyond 0.5 mm below the tooth surface or inside the periodontium. What will happen if we do so? That will come in the consecutive lectures that we will see about biological width. So another important thing is, in the periodontium, the part of the restoration which is going in should be smooth enough. If it is not smooth, there will be plaque accumulation and it will again destroy and hamper our periodontium. It's so duplicated in an impression without tearing the gingiva. That is another important. So how will we not tear the gingiva and make an impression? So we will be managing the tissue with the help of cord packers. We'll come that also in the forward lectures. Supragingival margin have no effect on the periodontium. Absolutely, they are very fine. It is only on the enamel. Subgingival margin, which is placed onto dentine or onto cementum, is a big question, where the periodontium can go into compromisation. So first of all, let's make very clear in our mind where all subgingival restoration is indicated and where it is not. So firstly, the advantage of supragingival, it is easy cleansable, it is easily visible, can be kept clean, it can be made easily without hampering the periodontium. Impression is easy, cord packing is not so required, easily evaluated in the recall appointment. Subgingival diseases, that is the periodontal diseases, has come, or where can encroach in the epithelial attachment. So subgingival margin is justified in cases of only, I say, aesthetics, nothing more than that. But it can also be done in cases where there are caries in the CJ cemento-enamel junction. There is little caries. Now you cannot afford to keep the caries over there and make your margin above that. You need to go beneath and make the margin so that the caries is also restored along with the restoration of the tooth. So more accurate and more time is spent in making subgingival margin. More caution is required while making the impression as well as while preparing the tooth. Excessive caution if conditions required that the finish line may be placed any closer to the alveolar bone than 2.04. What is this 2.04 mm? Now this 2.04 mm is the biological width which I was talking about. So this 2.04 mm comes by adding the epithelium and the connective tissue attachment. The epithelial attachment and the connective tissue attachment both comprises together of 2.04 mm. Gingival inflammation, loss of alveolar crestal height, formation of periodontal pocket, finally loss of the tooth structure, recession, and then failure of your fixed partial denture. So now let's see what is this biological width all about. So what happens is, your epithelial attachment from the area of, now this is the tooth, this is your alveolar bone, these are the connective tissues, the periodontal ligaments which are present, different periodontal ligaments. We have our cementum. From the cementum, here is the gingiva which is appearing. Now the gingiva which does not or is not supported by a bone or tooth is called the free gingiva. Now from the free gingiva to those gingiva which is attached to that of the bone, this section of gingiva is called the attached gingiva because it is attached. So the junction of free gingiva to that of the attached gingiva is called the free gingival groove. So now there is this epithelial attachment over here and we have a connective tissue attachment over here. So when we add this epithelial attachment and the connective tissue attachment, these both area total is 2.04 mm. So now if my preparation is from here, it is going beneath till about here. I am compromising the biological width. What will happen later on? This biological width compromisation will reduce the height of the residual ridge here. Now this residual ridge will recede down and hence we have compromised with the periodontal health and the biological width. So how is that 2.04 coming? So it is epithelial attachment 0.97 and we have connective tissue attachment that is 1.07. We added, it comes to 2.04. Is it same all over? No. For maxillary anterior it is different, mandibular anterior it is different, for maxillary posterior it is different, for mandibular posterior it is different. Why is that so? Because the bone level in every place which I spoke about is different. The bone level in anteriors are different, the bone level in the posteriors will be different. The gingiva, that is a free gingiva in the anteriors will be different, free gingiva in the posteriors will be different, and hence the attachment will also decrease and increase based on the area per se. The minimum and maximum 2.04 is considered as the biological width, which should not be hampered. So what we say is, from that of alveolar bone, your margin placement should be at least 2 mm higher, so that you are not compromising or affecting the biological width of the patient, of the teeth. When the margin of restoration intrudes the biological width, what will happen? Osteoblastic activity will start, and because of the osteoclastic activity is starting, what will happen? The osteoclasts will come into picture. Osteoclasts are what? Those cells which will destroy the bone. Osteoclast, clastic activity of osteum. So now what will happen? Osteoclastic activity starting, resorption of the bone, inflammation, redness, and there will be bleeding on probing in those areas. So alveolar crest is at least 2 mm from the restoration margin. This is the basic guideline that you are supposed to follow while preparing the tooth. Thank you.